Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, listeners, and welcome to another episode of the AOMT podcast series. This is Kevin MacPherson. Today, I have the privilege and honor of speaking to Beth Buzzell, and today we are speaking about her case series that she submitted initially as a poster back in 2016 and now in print as the title of Decision Making for Medical Referral During Physical Therapy Residency Training, a 3-case series of which she also worked with Charles Sheets. Now, before we dive too much into her cases, let's just give you a brief background of Beth. Beth is, she's a perennial at Duke from the looks of it. She did her doctorate training in physical therapy at Duke with a finish in 2014. And then she went through their residency program, which led her to further her training through their fellowship program with graduation in 2016. And she continues to work there with the likes of Derek Cluley and, interestingly enough, one of my previous students, which is going to be Zach Stearns. So it's really nice when we see how small this world is. So Beth, how are you doing today?
Yeah, I'm doing great. I had a good day in clinic, more red flag differential, and now I'm ready to talk about it again.
Fantastic. So Beth, real quickly, give us some insight. Do you actually teach differential diagnosis and medical screening, or is this just something that by nature you've picked up on? Give me some background.
Yeah, so I wouldn't say it was until residency that I really became passionate about this, just as far as considering what are the decisions we're making, how are we coming to those decisions, and kind of that more detailed process of clinical reasoning. And that's what led to this paper. And since then, of course, I did the fellowship training, which allows you that opportunity to break down your clinical reasoning even further. But I also have been a teaching assistant in the Duke Doctor of Physical Therapy program in their musculoskeletal content, but also their kind of a primary care practice course. And I've given a talk on this material every year since the residency.
Okay, fantastic. At Florida, I teach differential diagnosis, so this is definitely a subject that's near and dear to my heart.
That's what Zach Stearns mentioned in clinic today. So
yeah, it's definitely, I like the idea of us diving more into this subject matter, since it is an area that has direct care providers, or at least primary access providers, which is a direction we all hope to move as a profession. We need to be good at. So one, I'm going to thank you for publishing this, because I believe this is an area that our field needs to express more interest in and more publication. So that being the case, can you give us a little bit of background on the manuscript, and what were some of the driving factors that led you to publish this type of material as opposed to the typical case study that we normally see?
Yeah, so the Duke Orthopedic Residency is unique in that it starts with 6 months of inpatient training and clinical practice, and then you go to 6 months of outpatient clinical practice. So by the time, I was a resident, I had done my 6 months of inpatient, and, you're seeing the sick people, right? You're seeing the people that are having these spine surgeries and the more rare or complex cases. And by the time I got to my outpatient practice and I started seeing these cases in front of me again, I started wondering, am I too aware of what's going on? Am I being too careful? Am I screening too much? Or am I correctly identifying these more serious or concerning pathologies that do warrant medical referral? That's what led me to, with my mentor, kind of break down these cases a little bit more even do some of the statistical analysis of what is the probability that these patients have what, potentially have what I'm referring them for.
And that's really like something that I wanted to dive into it, because just, trying to teach the subject matter, obviously we always want to have that pre-test, post-test probability and try to mix that into our practice. But I mean, it seems overwhelming when you think of the statistics. So do you mind kind of educating the listeners that aren't super familiar with that process on what that looks like to have the pre-test, the post-test, and what you're doing with these cases?
Yeah, so it's a way of really explaining what we all do as clinicians. This as soon as a patient walks into your clinic, you're already observing things. You're observing their gait, or if they're guarding themselves, or things like that, and you're already starting to, in a sense, shift probabilities of what you think is going on with the patient.
Mm-hmm.
And I think especially for more serious, concerning pathologies that are rare, when that pretest probability that something serious is going on is that low, then your clinical reasoning really should consider those kind of nuances that shift your probability.
Okay.
So if you do a test and that test is positive, then that test alone likely isn't enough to warrant a referral. You need to consider next, okay, so what else should I evaluate?
That's fantastic. And that kind of comes into a discussion that I have with the students each year about what an actual flag is. And for us, the format that we use is a flag just simply means more questions.
Mm-hmm.
And it's when you get that overall picture that you start to come up with now at least a system that you're trying to refer out.
Yeah.
Now, since you also teach this and whatnot, give us an idea of like the way that you would present this construct to a student or a practitioner that really hasn't kept those medical diagnoses on the back of the mind quite as much as maybe somebody who had that acute experience and, by the sounds of it, might be a little hypersensitive. How would you help them out with trying to keep these on the radar?
Yeah, that's a great question. Mike Raymond is he's a manual fellow as well, and he is the course director of the MSK practice management curriculum at Duke. And he teaches something called the funnel, which is just a process of how you go through your examination of a patient. And within that funnel are steps. So the idea is when you start with the patient, your funnel is really wide. And then as you go down, you're ruling things out and doing less and less until the very end. So at the start of the funnel includes that kind of triage or red flag step. So that step can include anything. Of course, you're starting with observation or your subjective, but then potentially you're also in that early step doing any screening tests that you might be able to use. Realizing, of course, many of our screening tests, as we know when we look at the literature, have their own limitations. So it's just, a kind of that format for the students. They understand that it's an important step that should be done early on. It's something that we should really do with all of our patients is, really making sure, is this just musculoskeletal, or is this just, something that is changes with movement, or is there something more serious or sinister going on that this needs to be evaluated further?
And I think that's a great process. And I use a similar construct. Mostly what I look at is telling the students that there are really two guiding principles. One is you should try to rule the patient out of your clinic to start off with.
Mm-hmm.
And if you fail at that, then they obviously belong there. And then the second one is just prove yourself wrong, which means that if you're trying to prove yourself wrong and you fail at that, and we're talking medical as well as more of the traditional PT responding type diagnoses, if you prove yourself unable to really say that, okay, I tried my best to prove this is something I don't treat, then likely you got to the right place, which sounds very similar to the idea of trying to rule things out.
Mm-hmm.
So now you brought this up in your case series, and it was that you had a very large number of these referrals that came through your door in a relatively short period of time compared to what you would expect based off of some of the literature, kind of that 1% of patients probably don't need to be seeing you. Can you describe your population just so we have a rough idea of if there's some reason why you happen to have a little bit more of these patients?
Yeah, that's a great question. At the time I was treating in a hospital-based clinic, so it was actually housed in the hospital at Duke, some of the outpatient clinics at Duke, and a large referral source was the spine clinic. And the kind of cluster for cervical myelopathy that's referenced later in the paper, that study was actually done in that spine clinic at Duke there, where there was a prevalence of about 35% of the cervical spine evaluations did have cervical myelopathy. So while I wasn't in the surgical spine center, the clinic, the PT clinic that I was in is right next door to that. So I definitely would say not only are you in a hospital system where you're maybe getting more of those complex patients to begin with, but I was getting more of those, complex spine referral patients. So the only thing that kind of shifts it in the other direction is that my colleagues who I was in clinic with and I would talk to, they weren't seeing that same percentage of patients. And furthermore, if these patients are coming from the surgical spine center, then, in a sense, that probability in a way is shifting lower because they've already been screened for these things. So it's kind of in one direction, you can say that the probability of something, more sinister going on is higher. But then again, there also have been evaluated and kind of vetted through that process already.
Yeah, and I think that's interesting because, as I read it, as I considered where you were coming from, I kind of thought that there might be a chance that with your setting, you would just simply have a much larger group of patients that have a lot of comorbidities and therefore a lot of advanced risk for many of these more red flag conditions. But reading into it, it does seem that we had medical screening before that by somebody who is technically of the medical profession. So I did find that quite interesting as I was going through.
The clinic I work in now, there's still that higher probability of seeing something more sinister going on. And, I think that's for two reasons. One is what you just said is our patients do have a lot more comorbidities now. And just kind of the side of Durham I happen to treat on, we're seeing a lot more of those patients maybe directly from PCPs who aren't doing that thorough screening as much because they're managing medication and blood pressure and they're managing everything else. So, I think that now it's still higher, but I think it's both where I am, but also kind of our population of patients that are coming to us.
So now, since we've got an idea of your setting and we've got an idea of your background, let's go through a couple of these cases. And the one that kind of jumps out to me, Mr. Elvis Legs.
Yeah. And I would say that Elvis Legs is actually the line that first started my, to kind of pique my suspicions, I guess you could say. I would definitely say that even to this day, after residency and fellowship training, I still do a neurologic screen on any of my cervical or lumbar or thoracic spine evals. Not only to screen for, of course, upper motor neuron signs or things like that, but also because then I can tell the patient who may be fearful and have some of those thoughts that something's seriously going wrong with them, that I can say, hey, we know that nothing serious is going on. We know that, your nerves seem to be working as they should. Now we can just look at you as a person that has these different factors going on, and we want to address those factors. So with Mr. Elvis Legs, he was coming to me for low back pain and this kind of anterior leg pain. So because of that, I decided to do a more standard lower quarter neurologic screen on him, especially because he had said he was having more trouble walking recently. And that's when I found the 3+ patellar reflexes bilaterally. And when I did clonus, he had a positive clonus about 4 to 6 beats on the left. But his other upper motor neuron testing was normal, no other really negative Hoffman's, negative Babinski.
And then, did you happen to do? I know we're oftentimes limited with the word counts and similar. Were there other neurological tests or other tests that kind of clued you in on this patient? Because this patient ended up being. Well, I'll let you give the reveal. What was the end diagnosis with this one?
Yeah, so again, in a patient that had no complaints of neck pain or anything like that, this patient ended up having a pretty significant C5-6 and C6-7 disc protrusion, which resulted in the myelomalacia on the spinal cord, which kind of indicates that cell death in the spinal cord due to compression, causing those upper motor neuron signs or symptoms of myelopathy. So, yeah, for his exam, I did, because it was somebody who had low back pain. I was doing kind of strength, sensation, reflexes of the lower extremity. And when I was doing those reflexes is, of course, when I detected, more of that hyperreflexia and decided to pursue further and look at clonus and some other upper motor neuron signs. When I got those positive findings, of course, I wasn't thinking as much lumbar anymore, because with where the spinal cord typically terminates in most people, we're not even talking about the lumbar spine anymore. So I started asking him more questions about, do you have neck pain? Do you have any arm symptoms, any weakness? Are you dropping things more frequently? Some of those more questions indicating cervical myelopathy, and all of those were normal. So that's why, I was kind of, it seemed like a tough decision at the time, because on the one hand, he's not coming here for cervical myelopathy at all, but I'm also finding these things. So
Yeah, I'd like to talk to students about that, because it's the way I've always looked at this is kind of the fence. If you're on the fence of whether or not to refer, I remind them, probably 80% of the people that are walking in to get screened at an emergency room have referred themselves. So just that, knowing you have screened them, is a higher level than the vast majority of people that just show up to the emergency room. I think kind of gives some credence to what you're doing. And, lo and behold, at least you're also, in my mind, getting a little bit more buy-in from the patient, because you took that extra step to make sure it wasn't something bigger, right?
Yeah, no, definitely. And I've seen those patients that, do have myelopathy that got to a point where they, pretty much are needing assist for ambulation now. So I always tell the patient in cases, especially in this case, when we're talking about compression on the cervical spinal cord, it's still an unlikely, and I even told this to the patient with him sitting there, I said, it's still, unlikely that anything more serious is going on, but there's enough here that warrants this getting checked out further.
Yeah, definitely. Definitely a very good case. Which brings us to case 2, which is really kind of going almost the exact opposite route. So give us a little bit of a background and outcome for case 2.
Yeah, so case 2, again, this was still, during residency training. So you can imagine how you were in your first year of practice if this would walk in. But
I tried not to remember that.
So yeah, she had a long history of chronic low back pain, and when you see the physician referral, it's for L5 radiculopathy. So she had a unique mechanism of injury, though, in that she had a fall at work, and she had just sudden onset of weakness in her leg. So she went to the emergency room, and they ruled her out for a stroke with a CT scan. And then because she was still having that weakness, she ended up in a neuro clinic. Mm-hmm. So again, being evaluated by a neuro spine surgeon who, did evaluation, said, yeah, you're weak. Let's get an MRI. okay, that's showing that there's some protrusion on that nerve root. That makes sense. So let's send you to physical therapy. And, this was an interesting case because my residency mentor was actually here for this case with me. And talking about it after, he said that he was suspicious of an Achilles rupture, even, just during subjective when she said she had this fall at work and this sudden onset of weakness. Versus for me, I was still like, okay, subjectively, this sounds like L5 radiculopathy, and let me go ahead and do this again, lower quarter neurologic screen. And it wasn't until I took her foot into clonus to check for any upper motor neuron signs, potentially the cause of that fall she had, and there was just no end feel.
Yeah.
So her ankle just kept going into dorsiflexion. I couldn't get a quick stretch on it, and that caused me to then palpate. So maybe even though that is a special test, a palpable gap for an Achilles tear,
Mm-hmm.
I kind of bumped that up there just to feel like, why doesn't this have an end feel? And I could just palpate a very large gap in her Achilles, and then went ahead and did a calf squeeze test too, and that was positive.
So where were you rough time point on your residency training for this case?
Because I had those 6 months of inpatient training, technically I was in my, 7th or 8th month of clinical practice, but really my first couple months of outpatient practice.
I think it's interesting when you hear these stories, because obviously the mentor had that pattern recognition that just kicked in where they're already sensing it. They feel it. And the resident at that time, they're just starting to really build that up. And I've got to credit you, because you, instead of sticking to that anchor bias, you ended up jumping off and say, hey, this is not right. I need to change directions. So there's so much clinical reasoning just in that small frame that you just provided us. From that point, how did the plan of care change for this patient once you figured it out?
Yeah, and I think at that point it was a little bit more decision making, because of course an Achilles rupture isn't necessarily that critical medical referral, like go to urgent care, go to the emergency room or anything like that. So then it became a question of, okay, do we, these tests, while they have been, they do have diagnostic accuracy to them, do we go with this high suspicion of an Achilles rupture, or do we, and talk to a neurologist about potentially an ortho referral? Or is it safe to maybe see, maybe it's a partial tear and we can strengthen it? So, in talking to the patient, she had already been for, I believe it was 8 months or an extended period of time, she had tried to strengthen this up already. So given her significant weakness, her difficulty with gait, I kind of made that decision that loading that Achilles or trying to strengthen in any way was not appropriate, and that it warranted a referral to an orthopedist.
And then did you end up bringing the neuro on board with that first? What ended up being the final shakeout?
Yeah, so I think that's the definite advantage of working at a big health system like Duke, is that all of the providers are really quick, easy access, and I was able to message the neurologist, thank him for the referral, and just say, what I had found on exam. Not saying I think her Achilles is ruptured, but definitely that PT diagnosis that I'm suspicious of this because of these signs. What do you think? And he agreed with the idea of an ortho referral, and that's where she had MRI imaging, and that revealed the pretty significant rupture in her Achilles tendon.
Oh man, it's such a great case, because we also get to see the interprofessionalism that we're striving across the board to enhance. That's awesome. And now that leads us to the final case. So give us a quick rundown of the final case.
Yeah, so this one is kind of has its character in itself too. This was a 45-year-old male, and I would say for those who like working with persistent pain, or what that looks like, this would kind of be that textbook example. somebody that had a long history of chronic low back pain that seemed to be worsening over the last 8 months. And the other interesting thing is he had been to the emergency room 4 times in the last month. So when we think about our flag patients, this has its own flag, that this is somebody who is potentially high fear, just utilizing ED resources a lot, thinks that something potentially sinister is going on. So definitely a good patient to evaluate in a PT clinic. And we'd hope, of course, with, healthcare models, that they would come to see us even before those ED visits. So, clinical exam, there was definitely no true red flags, I guess you could say, on it. He had pain down both legs. He was having trouble sleeping, and really every movement made his symptoms worse. So, in evaluating this patient, I think, an interesting observation was that he just completely refused to do lumbar flexion, both because of pain, but, definitely there seemed to be a lot of fear there, and sometimes it's hard to tell. So his neurologic screen was completely normal though. So I definitely felt in this case he was completely appropriate for PT intervention, and this was before an MRI. And I only say that because, if we look at American College of Radiology guidelines, which I also find are useful to explain to patients sometimes too, is that if a patient has not tried conservative care yet, or they don't have those neurologic signs going on, then they're completely appropriate and in the right place. That PT is a great place for them, because it's a way to see over a course of, say, 4 to 6 weeks, what improvements can be made so that they don't need that MRI. Yeah, so I saw this patient, did a variety of interventions for him, pain education, a little bit of moving into his directional preference, a little bit of graded exposure into some of those movements he was more fearful of. And over the course of therapy, he still had 10 out of 10 pain, and wasn't still not sleeping and things like that. So that warranted at that point the referral to back to the doctor that had referred him.
And yet again, one of those great take homes from a medical screening standpoint is that continued red flag of non-progress, really not seeing them going forward. So I think, like, I love the case and the paper in general, because it gives students as well as practitioners a real chance to see some of the reasoning, see some of the progression, just across really 3 different types of referral mechanisms. You've got non-emergent there. You've got somebody who warrants the actual trial. You've got somebody who does have signs that say, hey, we should probably get this person referred out sooner than later. I think this has just been a really good offering. So that leads to the next question. Do you got future publications or projects that you're going to be working on?
Yeah, well, I just took over as co-director of the orthopedic residency here at Duke. So that's great in its own way, because clearly from these cases I have a big passion to discussing the nuances of what we do every day in clinic, and really that expert clinical reasoning process that goes on. So my current focus is definitely on continuing to establish and really grow that program that we have here.
Fantastic. How many students do you guys take now?
We take one a year as of now.
Okay, I was going to say it's still a pretty tight program, if I recall. Yeah.
Yeah, and when I did it, I had a co-resident, and that's something I always push for, because obviously I think the more minds you have just talking through cases like this, the better. And that's something I love in my current clinical practice. I'm with 2 other full-time clinicians, one of them, being a former student of yours, as we mentioned. And we do this every day. I mean, every day, whether it's a challenging patient presentation, or one that we're trying to decide what is the appropriate next step for this patient. I just think it's so valuable, no matter how many years out you are, to have those conversations.
Yeah, and that is definitely something I miss from when I was at the University of Illinois, working in the University of Illinois at Chicago's fellowship program. Was just the interaction between all the fellows and the fellows in training in that back office of the clinic. You just can't replace it. And fellowship in general is just so rewarding because you do get exposure to a lot of this. And, with you having gone through fellowship and possibly some of our listeners also considering it, what recommendations or what kind of advice would you give to a clinician who is thinking about trying to go through this training?
Yeah, I think it's a great question, especially now when residency practice is becoming more, I guess you could say, the norm or more common to do. I think fellowship training is special in its completely own unique way because, in residency training, typically it's about getting those fundamentals down pat and making sure you're doing the basics really well and maybe not missing patients like this. Whereas in fellowship training, you can take it even that step further where you're still discussing clinical reasoning, but you're potentially really diving into treatment effects and manual therapy and how can you apply it, on what patients should you apply it or can you apply it. And I think it's even that much more dynamic. And the skills that I got both with my hands-on techniques, but then also my ability to reason and look at even evidence with that critical eye in a good way, I think is an invaluable part of fellowship training.
Indeed. Well, Beth, I'm sure we've got some listeners that may have some questions coming up for you. Do you have any ways that they can get into contact with you to ask you any questions?
Yeah, definitely. Any questions at all, you can email me. It's Bethany, Bethany .Buzzell, Buzzell at Duke.edu.
Well, Beth, it was great talking to you. We look forward to you building up an even stronger residency program and also seeing your contributions to the association going further. So I hope you have a wonderful day, and we'll see you at conference, hopefully.
Great. Thanks, Kevin. Thanks so much for having me.
Sure, not a problem.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.